So, as you all know, uh, we are going to have a very important session today. So, total care. So, and psychosocial aspect being an important aspect of total care, we are going to deal with that topic today. So, with us, we have one of a vital member of our team who helps us in rendering the total care to our patients. So, that is Ms. Treesa Varughese. So welcome Treesa to the session and over to you.
Thank you, Dr. Amrita, for the kind introduction. Hello all, good to see you all today on this platform today. Myself, Treesa Varughese, working as a medical social worker in Palliative India since 1 year, and I was mostly involved in the home care as part of palliative care setting. Today, I'll be taking you through the psychosocial aspects of care. So, when we talk about palliative care, from the previous sessions you had, I think it's very clear about what exactly we deal with in palliative care. It is more of a holistic care. So when we hear the word palliative care, there are many words that randomly comes into our mind, right? So it can be symptom management, maybe it can be end of life care, it can be many other words like a multidisciplinary team, it can be pain, maybe. So there are random words that comes into our mind when we think about palliative care. One of the important aspects that has to come into our minds when we talk about palliative care as such is what I will be talking about today. That is the psychosocial aspect. Psychosocial, as you hear, it's a combination. It's a blend of two words. The psyche, that means the individual, and the socio, it means the environment. That is the person in the environment. That is what is actually meant to the psychosocial aspects. Why the psychosocial aspect is included in our care is because a critical feature of individualized patient care is identifying and managing the psychosocial issues along with the medical issues. In the hospitals, it is very sure that the physical aspects will be taken care of. And along with it, what we have to take care is the psychosocial issues. So hopefully you have all come across this World Health Organization definition regarding the palliative care. Just to revise on the same definition that we have already discussed, palliative care is an approach that improves the quality of life of patients as well as their families. That has to be given a special emphasis on. That is, it is not only for the patients, but it also encloses the family in which they belongs to. And those, so the quality of life of patients and their families facing problems associated with life-threatening illness, also life limiting illnesses can be also included in this, through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems. They are physical, psychosocial, and spiritual aspects. So it is a totality. It's a holistic care that we are supposed to be provide through palliative care. The main aim or the primary goal is to improve the quality of life of patients, and the four different aspects that we will be taken care are the physical aspects, the social aspects, the spiritual, as well as the socioeconomic aspects. So I think we have heard about this concept of total pain. The total pain, that is when a person comes into our setting, what we ask for is like we have a pain scale, right? So in the pain scale, when we ask for a total pain, they say a number. But does it means that the pain, it is just that of physical? It may not be, or it may be. So in the concept of total pain in palliative care, what is meant is that the physical pain which is reported by the patient is compounded by the current life circumstances that he or she is currently in. That is, it can be the other factors, that is it can be some social factors that is contributing to the pain of the person. It can be some psychological discomforts or distress that is happening within his mind, that is contributing to the total pain. So it can be a totality of all these things that causes the total pain which is reported by the person. So there comes the importance of the term social diagnosis. As doctors, if we are like well aware of the clinical diagnosis that you make. So along with that, what we also should have is social diagnosis. A social diagnosis can be called as an understanding of a psychological, biological, social, and environmental factors which is operating on the person in his situation. So, considering the person in the situation in which he is currently in, we are considering the psychological factors, the biological or the physical factors, the social factors, and the environmental factors. So, along with all these things, we make a social diagnosis of the person. As we told, the illness related sufferings, it is much more than just physical distress. The total pain, the other concepts, that is the psychological, then the socio-economic, the spiritual aspects. These four aspects has to be understood in total in order to understand what exactly the person is going through. So I'll be putting forward a question like, why is psychosocial care important in palliative care? Why exactly we are trying to deal with psychosocial care and palliative care? Usually in hospitals, we do care about the physical aspects, that is given very important. And why in palliative care, or why are we focusing on the psychosocial care? Why this psychosocial care or psychosocial aspect is included in palliative care is because very often in palliative care, we come across people who are going through certain crises. It can be like an unexpected prognosis. It can be people who are going through grief, who are about to lose persons. So all these things, like the people will be having some crisis in their life. Such crisis, even if we are having like personal crisis in our daily lives, what we do is like we exactly need a support of an external person. That is where we comes in. As health professionals, we do have to care for the psychosocial aspects. We do have to try to make an understanding regarding the psychosocial aspects, so to make proper interventions for the person. So why is psychosocial care important? The two points that I have noted is living with a life limiting or life threatening illness. So a life limiting illnesses can be a traumatic injury where the person is confined within the room, or it can be some geriatric issues can also be included because the person's life is being limited. The life as such, it has to be considered in a bigger aspect that we have to consider. So when considering such an aspect, the life limiting illnesses which restrict the person from having a proper or normal social life, that can be included in palliative care. Also, for the life threatening illnesses like advanced cancers or the awareness of approaching death in a person, it causes unique stresses and challenges in one's life. So we all may be knowing that whenever we have attentions or whenever we have, I don't know how many of us will have such experiences, but whenever we have such experiences, we'll be having unique, the stressors will be there. Like whenever we are having some diseases, what will happens is like we'll be tensed about what is going to happen. It is actually adding up to it is increasing our stress. So this challenges and stresses are more compared to the other persons in a person who is living with life limiting or life threatening illness. Also, a serious illness, it can disrupt the individual's thoughts and feelings, the relationships, that is within the family before and after illness. If we trace out the relationship within the family, there can be a change. There may not be a change also. It is subjective. It depends and it varies from person to person. But what happens is that it may disrupt the relationships of the individuals within the family as well as with the extended family. Then regarding the social and spiritual supports, prior to illness, maybe the person was receiving ample support from the workplace or from wherever he was an active member in which. But after that, after the hospitalization or after the illness, the post illness that time, maybe like the social support systems that be withdrawing. So there may not be social support systems, but there are situations where the social support systems got strengthened due to this illness or something. So there can be changes in such areas. Also, the spiritual supports that can also be changed. Then the financial stability. We all may be aware of the fact that the hospitalization can cause financial instability in a family, because the medicines or the treatment procedures, it can charge so much that the family may not be affordable. So that can create a financial instability in the family. Also, the spirituality of a person, that can also be affected as part of the illness. So this, like, it is like there are many areas of a person that is being affected when a person is diagnosed with a serious illness. So why we are taking care of this psychosocial aspects other than the, like, after the physical aspects, is that this disruption or this equilibrium of the person's family or person's life has to be maintained by us in a possible way that we can. So for a person who requires an external support, who is dependent on others, what we can do is, like, as health professionals, we'll be able to do many things for that. So in order to have a proper understanding of a person, we have to have a clear understanding about the psychosocial aspects too. This is assessment. So assessment, generally called as an exploration process, which is about the gathering of informations. It is about the person. It is not usually like a questionnaire or something. We all will be knowing that it is generally a casual interaction from which we'll be exploring more about the person. We'll be using open-ended questions through which we will be gathering informations about the person's family and other informations. Then why this assessment is important is because the selection of goals, like whenever a person gets admitted to a hospital, we'll be having a set of goals to be achieved by the end of discharge. So it will be based on that goals that we'll be making our intervention plans. So why assessment, or why proper psychosocial assessment is required in palliative care, is because our selection of goals and interventions, it largely depends on what is being assessed. For example, for a person, if they comes in to a hospital, they just reported about the physical issue, and we made a goal, that is the physical issue has to be managed. Then based on that, the intervention has been made at the end and the person got discharged. But what happens is, like, there may be other invisible factors. There are hidden factors that we may fail to understand. So at that times, what happens is that by the end of discharge, the pain may not be reducing. But if we consider such aspects too, it will be much better for the person, and it will be a much relief for the person who is actually experiencing a total pain. The aim of assessment, it is to identify the problem areas which resulted from the illness and may influence the well-being of patients and family. So what exactly is included in this is that there are many areas that influence the well-being of a person, and through assessment, what we try to understand is these areas which have been affected through the illness of the person. And what assessment involves is that it is collecting of informations. It is also identifying and honoring the strength, the resources, and understanding what exactly are the needs of the person. So among all this, what we need to understand is considering the patient as a person. As a person, what are his needs? Rather than physical needs, what are the other needs that have to be met? What are the other areas that are to be intervened at? So in order to understand all this, we should have a clear understanding. So all these things, what we can do is we have we can seek the help of the other members of the interdisciplinary team. It can be a counselor, it can be a medical social worker, it can be us too. Like, for all this understanding, what we really need is to have ample time to be spent with the person. So when we have ample time to spend with the person, we'll try to get to explore more about the person. We'll try to understand more about the person, and as such, we'll be getting an idea of what exactly is the person as a whole. So that understanding will be only possible when we get ample time with the person. Assessment, and it is not only an initial process, it is an ongoing process which begins during the initial the first meeting, and it processes and it goes on along with the admission, and also it happens even after the discharge, even post discharge period we'll be having assessments. Because why we say that it is an ongoing process is because the psychosocial needs of the patients and the family or caregivers, it often changes over the course of illness. It is not like the psychosocial need is stable, because during the beginning of the illness, maybe like there are supportive systems for the family, the relatives, they are well enough and they'll be supporting the family. But as in course of time, when they get to know that they know the expenses are getting higher, the there are many issues that is happening in between. There may be a lack of support system that is there for the person. So during the initial time when he have enough support, his needs were different. He may not have like a very clear cut needs during the initial time, but as in course of time, as the illness is progress or as the illness moves forward, what happens is that the support systems or the relationships that may weaken, or there can be newer issues coming in for the person to face. So what we need to understand is like we have to revise on it. We have to have an updated version of assessments, and whenever possible we get to talk about the person and which all informations are missing. In the next meeting we'll be trying to understand that areas. So all this happens because just to understand what are the psychosocial needs of the patient at that point of time. It may vary, and based on that, we need to understand what exactly are the needs of the patient. How exactly this assessment is possible is through purposeful observations and conversations. That is, observations we say is like the person, how the person interacts with you, the tone of voice, then the gestures. Is he like keeping eye contact with you? Then such non-verbal cues can be considered as an observation. So with which we will be getting to understand about what exactly the person is meaning. But the thing is about the observation of nonverbal cues is that only through experience that we'll be getting to know, or we'll be getting to understand how to interpret all these nonverbal informations that the person is trying to say. But with a general understanding, we can also be with the person and we can try to understand whether the person is comfortable with us, whether the person is opening up. Like for example, maybe a person can conceal informations as the doctor or the social worker or whoever is talking to the person is completely new for them. They may conceal the informations. But once we build a rapport, once we have a casual conversation with the person, slowly as time goes, the person gets open up with you. The person will be more expressive to you. They will be talking about their personal things, and such a rapport has to be built along with the person as well as the professional. And the purposeful conversations include the way we communicate with them. So already I think we have had a communication session. Many times we'll be talking about communications. What exactly are the ways that we will be talking to the person? How like what is not to be done and what is to be done. So it has to be like purposeful. We have to have an idea regarding what exactly we need to understand. We are seeking for informations, and so we'll be having the purposeful goals. That is, these areas has to be understood. But it is not about asking it question by question. It is about a casual talk where we get to know more about person. We use open-ended questions like, "How are you feeling? Let me know about your family." So such open-ended questions can be used in order to understand information from the person. About the sources of information. Usually, what we have as a source of information is the patient or the caregiver. Usually, in here, we will be having the caregiver, who is the first or the initial information source. Also, the informations can be collected from collateral sources like friends, the relatives, and neighbors can be considered as a source of information. Like when the patient or caregiver, they may not be in such a situation to express fully during the initial interview. But if you have someone like accompanied with them, if it is a friends or if it is a relatives, whoever it be, what you can do is like we can ask to that person regarding who exactly or what exactly is the person's condition, what is the environment in which he is coming from. All such informations can be collected from collateral sources too. Home visits are also one of the main and important source. for collecting information regarding a person. But in all settings, it may not be possible. But it will be much better if we have a home care team. So to understand more about the person, like when we only when we get to understand the place where he or she lives in, we'll be getting an exact knowledge about what exactly is the area from which he is coming from, what exactly is his living situation. So such things can be only understood during the home visits. So just to explain two of the pictures that we get from the home visit is that the first one, it shows the payment through a person who was bedbound. And once we have asked them for a review and we have asked them to come for the next visit on the coming day, what they said is like they'll be coming, but they failed to come. And they reported that through the phone call. We have inquired about the issue, and they said you need to come home and please do care for our father. So we made a home visit, and this was a way through which the team has to go through in order to reach his house. So the person was bedbound and he was also like using wheelchair. What what we use is like what they said is like only whenever the person have to be taken to the um, road, that is taken to the ambulance or a vehicle, there should be other people to carry him from home to this road or pavement. So why he is not coming to the hospital was because he was not having proper accessibility to the like they don't have a proper wheelchair accessible road. They don't have enough support from the others every time they require. So in case of emergency, it is not necessary that there will be people nearby to help the person carry him from the house to the ambulance. So these are the difficulties or the barriers that prevent the person from coming into a hospital setting. So whenever they come to a hospital setting, what we need to understand is like whenever they come, they are coming from a different situation that we may not be aware of. So these these are the areas which we fail to understand. But whenever possible, if there is a chance, try to understand what exactly is the place or what exactly is the area from which he is coming in. And the second was also another picture, that is when we asked whether he was having a home, he said yes. But only when we get to have a home visit, we get to understand that he was living under a tarpaulin sheet and the condition of the house was very bad. And it was a patient as well as a caregiver who was living inside that. So only through the home visit, we get to understand about the real condition of what exactly the persons are coming from. Why we say that these informations has to be considered is that whenever we talk with the person, we also need to know what exactly are the situations, what are the concerns that the patient is having, what are they hiding from them. So such areas which we fail to understand are actually the areas that needs to be intervened upon. So only when we get to know about such situations, we can be doing something to help the person to get access to the hospital as like whenever he or she needs it. Just like I'll be taking you through a case study just to have an understanding about what exactly are the aspects that needs to be understood. So a 33 years old lady, Miss A, she has been diagnosed with CA rectum in 2014. She had chemotherapy and radiation followed by colostomy. She was referred for pain management to our palliative care, and at the time of registration, she presented with severe pain, infection, and foul smell from the colostomy site. She looked very anxious and scared and has no idea about palliative care. From the medical records and the present disease progression, the team had an impression of a very bad prognosis. She's also a widow, and her sons are 11 and 8 years old, respectively. This is just a brief of a person. So from this case study, what can be the important areas that are to be assessed from the point of view of total pain? You can give your responses in the chat box so that we can read. So just to consider as a case study, this is the brief of the person, that is Miss A, about her family. Then what are the areas? What are the important areas that are to be assessed from the point of view of total pain? What exactly may be the areas? Okay, young children could be the primary concern of the person. Okay, so that means the family overview has to be understood. Then anxiety comes as a psychological area, so the psychological aspects have to be understood. The colostomy care, so the physical aspects of the person has to be considered. The education of kids, that comes in the social aspect, that has to be considered. Yes, finances, that is also included in as part of socioeconomic. So thank you for the answers. So we'll be moving on to what exactly are the areas we use in assessments. A few of the areas are included in this, and you can also add upon this. So the brief is like we should have a patient overview, that is about the basic demographic details about the person. What exactly was his educational qualification? What was he working? What is his illness before and after illness? So all these things can be understood. A general patient overview can be there. Then regarding the insight is an awareness or understanding about the state in which he or she is in. So it can also include the insight about the diagnosis, the prognosis, as well as palliative care has to be included. Then the family overview, that is what is the structure of the family, who exactly belongs to the family. All these things has to be included. Then coming to the socio-economic overview, how the like as the doctor have mentioned, like as the how the finances are being managed inside the family, what are their social support systems, such things has to be understood. Then the psychological overview, which includes what are the psychological discomforts, what are the distresses that are being caused, what are the anxiety, all these issues can be considered under the psychological overview. Then the spiritual overview, which will be dealing with the connections about the hope. It's not about like just about the religion or faith. It is like a more of a detailed concept which includes the concerns, the hope of a person. Then what exactly are the connections with the connections that the person is having. All these things are included in the spiritual overview. And then psychosexual overview. At times we fail to understand this because sometimes we will be uncomfortable talking about it. But this is also an area where we have to have an intervention on, because such areas will be also concerning the person, and it will be contributing much to the total pain of the person. So such areas has also to be explored on, and based on all this we make a common intervention and a plan will be made according to that. So in all these things, what we need to understand is that we should work as an interdisciplinary team. And whenever this like a detailed assessment is not possible for the doctors, what we can do is like we can seek the help of the counselors or the medical social workers. So as an interdisciplinary team, we should work together and we should have a common goal, so that with that we will be making proper interventions and thereby including the quality of life. So this is an example of a genogram. I hope we have all seen genograms in some of the other case sheets. So this is just a representation of a genogram. It's a family tree where the informations include the name of the person. Then the relationship will be the relationship that is marked through the lines. Then the educational or occupational profile is written below the names of each person. So considering this person, the lines actually shows the relationships. That is what is mentioned to our relationship. So looking at the genogram, we'll be able to understand what exactly is the structure, what exactly are the persons living with. The circle, it denotes the immediate family. That is, Miss A is living with her two children, two sons. Husband has passed away. So this is it. And the thickness of the line, it shows the strength of the relationship. And this exact line, it shows the hostility towards um, the husband's family. And the other lines, that is the positive relationship with her own parents. She's having a positive relationship. So this will be a snapshot overview of what exactly is the structure of the family. This are some common legends that we use to represent the offsprings in a genogram. And these are how, like, the emotional relationships, like as I said, the plain relationship using a symbol line, the intimacy using a double line with thickness, the hostile or the relation, and the very closely drawn zigzag line, it shows the violence. So why this can be denoted in a genogram is that from a fraction of second we'll be getting to understand what exactly is the family structure looks like, who can be approached at, who can be who can be called upon when the patient is actually in need of something. So this is why all such informations are included in a genogram. And this concept is of ECOMAP. When genogram talks about the relation of the person with his or her own family, ECOMAP shows about the relation of the person with the larger society. So the usual headings that comes in the ECOMAP can be the schools, the health services, the extended family may be there, the neighbors can be included, the workplace, the government services, or the systems, the local services available, and then whether they are getting help from any religious institution. All such informations, like all those other than the immediate family, can be included in the ECOMAPs. So in ECOMAPs also, we can draw it like this. Inside the circle, we can have the family. This is just an example of an ECOMAP, how to draw it. So the legends are explained at the top. That is, this straight line shows the positive relationship. The dotted line, it shows the tenuous or weak relationship. The zigzag line shows the stressful, and the arrows. See the arrows, it shows the energy flow. And if the arrow is drawn on either side, it shows that there is a mutual relationship. And the line thickness, it shows the intensity of the relationship. So this is how we can draw a ECOMAP. So in this picture, when you want to understand the person, see, for Greg is very close to church and also to the counselor or the youth mental specialist. So this is also a snapshot view of the person's family's interaction with the larger society. That is what is understood through a genome. That is what is understood through an ECOMAP. Okay, moving on to the possible social impacts of illness. So, what could be the possible social impacts that can be caused due to illness? For a person who is living in a normal life, he may be suddenly diagnosed with a disease, and what can be the possible social impacts of a illness? You can put your answers in the chat box. There may be many issues that is coming in with the person. He was having a very proper life, and he was just starting with few symptoms, and then he moves on and he had a diagnosis that was very unexpected. And what exactly can be the social impacts of the illness or the hospitalization, or what can happen? Okay, there are answers coming up. So there will be stigma. Okay, there are even stigma associated with many of the diseases even right now. Then isolation can be there. Long-term hospitalization can lead to isolation. That can be a social isolation as well. Then there can be self-stigma will be there. So there are people who will be who fails to go out. I personally so there are self-stigma will be there. A stigma that is directed towards oneself will be there. So all these things happens. So leading with the possible social impacts. So this is a short list of what exactly are the possible social impacts that can happen due to illness. As the doctors have mentioned, there is social isolation that is happening. So once you are diagnosed with some illness, what happens is like mostly you will be engaged in hospital visits, or you will be confined within your home. You will not be taking part in any of the common programs like a marriage, a church feast, or like any common programs. You won't be able to attend all those meetings. So there will be a social isolation from everything. Then there will be dependency. For everything you need to depend on other people. You don't have an autonomy. For everything you need to depend on persons. So such things happen. Then financial instability, that can be a higher impact of social illness. Then lack of social support can be there. Then huge deaths due to hospitalization and the other charges included. Then the loss of work, maybe the person when he was working before, and due to the illness and its after effects, he may lose his work. He may be unable to go for work. So there is a loss of work that is happening. Then there can be interpersonal issues that is happening within the family. There will be role changes when the person, when if the head of the family, if the person gets an illness, and what happens is like the female or the spouse has to take up the role of the head of the family. So there will be issues happening within the family. Like they will not be much focus on the child rearing. So issues can happen within the parents and children. No proper care will be given to the person. So such interpersonal issues, that maybe the illness can also be a burden for the family members. So the interpersonal issues can happen. Then inadequate facilities within the home, that can also be an like what is an impact of the illness. Maybe like the person has become a wheelchair bound, and the house is not like it's not wheelchair friendly. There is no ramp. There is no ramp to the bathroom. If the person is not having accessibility, like the inadequate facilities inside the home can also be a social impact that can affect the person's life. And coming to the possible psychological impacts, there can be a feeling of shock and uncertainty or hopelessness for the person. Then there will be anticipatory grief, that is a grieving on something that is about to happen. So what will I do when I lost this person? What will I do next when I lost my mother? So such a loss or a grief about something that is about to happen, that may happen, and there will be poor insight. So there may be people with lack of awareness or insight regarding the diagnosis, regarding the prognosis, or as well as palliative care. Then regarding anxiety can be about death or about the future life. What exactly am I going through? How exactly I will be living forward? Such anxiety or anxiousness can be there. Then the suicidal ideations. Suicidal ideation can be like the chronic illness. It is a significant risk factor that is leading to suicidal ideations. That is, people will be thinking that why should I be a burden to the family? Without me, maybe the family can have a proper life. So such things can lead them to have a suicidal ideation, or they want the death to be fastened. So such issues can happen inside the person. Then poor coping with the illness, the person may not be accepting the fact that I come to have this particular illness. So such coping issues can also happen as part of the psychological impacts. So what exactly is the problem is that these psychosocial as well as the spiritual sufferings are real and are there within the person, but it is very difficult to recognize and treat them. That is why what we say is that we need to have keep on understanding. We need to have a proper rapport with the person. We need to try to explore the person to understand what exactly is going through the mind of a person. And the physical complaints that the response is that can also be the manifestation of these issues that is happening within the person. So that is why we need to have a clear understanding about what exactly is going through the person's mind. This is a form of spiritual assessment. You can go through that. It is more of like a connection, than the meaning and joy of life. What exactly they make out of their life. What do you mean about your life? Such questions are included in this. Then the strengths and comfort of the person, the hopes and concerns, all these things. Like if they have some unfinished business to be done, like such situations are included in the spiritual assessment. This is actually a model of a spiritual assessment, and the contents in this can be used as part of our spiritual assessments. So I hope you remember the case which I have just mentioned before. So based on the parameters, these are the assessments that we have come upon. We have collected many like more details was collected, and what we have done is like we have tabulated it in separate columns under different headings. Coming to the physical area, what the person was going through was a physical pain, then the discomfort due to colostomy bag, then fatigue was there, body image issue due to this colostomy bag was there. Then she was also having lack of sleep, and the lack of sleep can also be a manifestation of some psychological issues or concerns that she was having. Then the psychological area includes the anxiety about the future or about children, then unclear about the prognosis and palliative care, and also she was having like suicidal ideations. Then isolation and stigmatized from the family. Also, as she was a widow, she was grieving due to the loss of her husband, which was her only support system. About the socio-economic, she was having a very strained relationship with her husband's family because her marriage was not as per the arranged marriage that was made by the family. They married with love, and so there was a strained relationship with the husband's family. She was also working as a saleswoman, but due to this physical health issues, she lost her job, and now currently the family does not have a breadwinner, and there was financial instability in the family, and there was huge debts due to this hospitalization. The house they live in is for rent, and the education of the children and the treatment of children. The children was also diagnosed with epilepsy and nephritis. So their treatment was also should be spared by her. So all these things has contributed much to the socio-economic aspects. Then coming to the spiritual, so the person was having extreme spiritual distress, and she was thinking like, why exactly all these things have happened to me? Like the entire family, the entire persons, the four members of the family was diagnosed with some or the other illness, and so she feels like the family was cursed, and there was loss of faith in God, and the loss of connection with family, friends, and community was there. Then she was not interested in any activities, doing any activities, and she was also losing her hope about life because of all the sufferings that she had come across in her young life. She was only 33 and she had come across all these things. So considering this, what we need to understand is that just to see about the physical, so that is a small aspect. So all the other aspects just contribute to the total pain. Why we need to understand is this: these are the areas or these are the concerns that actually the person is having. So only when we solve all these areas also, or only when we address these areas or try to identify these areas and do some interventions, the person will be relieving from her pain that she is going through. This was the gene ECOMAP of the person just I have mentioned. The person was receiving help from the church, RCC, local volunteers, and Palliative Media was supporting the person. So this is just an example of the ECOMAP. Okay, that is what I have to talk about this assessment as such. So it is very important to understand the the different aspects that is contributing to the total pain of a person. And coming to the dignity, which is also included as part of this care, is just to have there is a quote written that is the inability to acknowledge personhood, the insensitivity of not acknowledging personhood can be psychologically devastating. Both this, that is, dignity has to be given importance. A person has to be like dignity has to be given to a person. And just to introduce with the ABCD of dignity, it is A is the attitude with which we behave, we look upon a person, and B, it stands for the behavior, how we are actually behaving to the person. C is the compassion, or how genuinely we are interested in making a change in their life, so that compassion is included. And D, that includes the dialogue or the conversations that we make. So this is a simple question that we can have in order to understand what exactly the person is going through. What do I need to know about you to help you better? It can be different answers. It can be simple answers like I need to go to a beach. It can be like there may be many wishes that is there in the mind of a person. So it can be different. So just to have a casual understanding rather than talking just about the illness, what we need to understand is we try to understand the person as the patient as a person. So this can be as a leading this can be a question that you we all can ask to a person who has come to us, that is, what do I need to know about you to help you better? These are the photographs of a person who was in our IP, and what he really wanted is that he wants to celebrate the wedding anniversary that is about to come. So that was the last wedding anniversary that they have celebrated. So about coming to the intervention part, the possible interventions that we can do based on our assessment are informations, that is dissemination of informations can be done, that can be even regarding palliative care, then breaking the bad news, that can also be included in this, then licensing, then facilitation can be done, like if as health providers we may be knowing about the health systems or the available services and schemes for the patients and families, so facilitating them to the support systems can be happening. Then rehabilitation, if needed, rehabilitation can be considered. Then follow-ups should be done in order to understand what exactly is the progress of the person. Then supportive counselings, if needed, can be provided. And if we are not able to manage as by ourselves, we can refer them to a counselor, that is a counseling psychologist can be referred to. Then psychoeducation, maybe the caregiver can be educated regarding all those procedures of the hospital, what exactly are the procedures that they are doing, about the medications. All these informations are included in the psychoeducation part. Also, the palliative care, it does not end with the death of a person. We extend the support even after that. That is, the bereavement support has to be provided to the family in order to cope up with their loss or the grief that they are going through. And these are the photos of some vocational rehabilitations that we have done. And the vocational rehabilitations will be based on their interest. So there were candle making, the goat rearing, umbrella making, such small scale activities will be taught to them, and that will be an earning process for them. And this is where we support children. We have a facility to support children for educational and emotionally. They have a support group. And to remember, to conclude, or to always to remember about what exactly psychosocial aspects are, to evaluate our interventions. That is, whatever we are doing based on the goals, that has to be evaluated properly. And we need to assess how the patients or families are benefited with our interventions. This assessments, it has to be revised and it has to be updated. You can have an interdisciplinary approach in order to have a common understanding about the person, and good documentation is very valuable. And whenever possible, we can use the research validated techniques. And to remember that is there is an art and science in psychosocial care just as in medicine. So the psychosocial aspects also need to be equally given importance along with the physical aspects in order to have a proper care, or in order to improve the quality of life of a person as we all wish for. That is all about my presentation, and thank you so much for listening.
So thank you, Treesa. That was a really enlightening session, and I think all of you have made advantage of that session. So she has taken us through the importance of psychosocial care and the importance of establishing, as the patients might have lost the equilibrium, or the importance of establishing the equilibrium with the psychosocial care that we can provide them, and also with the proper assessment and how to make the assessment. She has taken us through that, and also with the ABCD, that is attitude, behavior, compassion, and dialogue. So I hope everybody, the session was very useful for everyone. Uh, I would like to hear comments from the team, from the participants. So please, you can use this time for clarification of any doubts or queries to the faculty, and also add your comments. Am I audible, Raju?
Yes, Doctor, you have.
Okay, thank you.
So Treesa is working as a social worker. She's more into home care activities of Valley India. So any questions regarding that, you can come up and ask. Dr. Amrita, we are having a question.
Okay.
Any tips on how to access total pain quickly in a busy OPD setting? Dr. Susan have asked it.
So I think, as Teresa has already, would Teresa like to comment on this?
Um, okay, that is the question is very like the question is very necessary one. That is, in OPD setting, what happens is like we come across many people and we will not be able to get more information regarding that. So what exactly we can do is like we can have like the like cues can be written already. Like we can have a set or we can now have an already prepared initial assessment where the important areas that need to be understood can be included in this. So as soon as as like very fastly we can be collecting information from that person. We can note the important areas that have to be assessed. The family overview can be, that has to be included. From the genogram and the ECOMAP, it will be very clear about the family as well as the external support. And just to have a other understanding is like another important area that can be understood using the during the initial assessment is the socioeconomic overview. You can maybe frame a questionnaire or frame a point like interview schedule, such a like cues can be included so that better you can collect information fastly from the person.
Dr. Amrita, you wish to add something?
Yeah, exactly. I'm agreeing with what Treesa had added. I understand, Dr. Susan, that it is not always easy to get ample time for assessment in a busy OPD, but it would be recommendable that once you, as Treesa has mentioned, a quick assessment is done, and you find or you feel that the patient needs a bit more assessment or bit more psychosocial support, then you can spend a bit some more time for that particular person. And every person in our OPD might not be needing the same equal time. So that could be another, like we can consider doing it in that way also. That is what I suggest. I would like to hear from other participants if they would like to comment on this. How will we handle such a situation in a busy OPD? How to deal with the psychosocial care in a very busy OPD? Does anybody has any comments on that?
There are two comments from my side. I'm Vandana from Raxol. In a busy OPD, many times we also have we can do referrals to our own, counselors or clinical. Sometimes not clinical psychologists, but counselors or social workers or project staff. So we do that because many a times because it needs a patient intervention and understanding, and sometimes even the nurses, there are very good nurses, who could be trained on this kind of understanding the psychosocial aspects and then follow it up. Second is, what we in our setting, what we do is, we can't do for everyone, but if those who come under like that, we do the grading, and those who are really vulnerable or the ones who can actually come under our or we can say those who are graded poorly, so we can take those patients initially with the ranking, and then first work with those patients, and then also refer it to the community department if it is attached to the hospital wing. Then and if it's falling in those target areas, even sometimes it's important to do some home visits too. So so this is two things that we follow. One is, if the doctor is very busy and there are a lot of things happening, refer to the to the social worker or the nursing team. But then it has to be, the doctor has to follow it up and at a later date. There has to be a communication. Second is the community health department following some of the patients who are falling in their target areas. So that is that's how we do, because it's not only talking the psychosocial component, actually intervening also at different levels. So we had been able to intervene in areas of financial support in terms of livelihood initiatives, restoring relationship between family members, or the social discrimination that they had. So we went and started doing, there was this one person who had this who had this mouth cancer and this whole, like, so our staff, they went and did the whole beard thing and did a very good home based care, and the people around the community started knowing, no, it's not a communicable disease. So, and after some time they started calling him in functions and social other gatherings. So that's how we do. So this two thoughts.
Yeah, thank you so much, Dr. Vandana. It was Yeah, actually, that is the multidisciplinary approach that is being highlighted here. I think that is a very good effort, and it is a wonderful effort being done in your institution. I think it is recommendable, can be followed in other places also. We are also following a multidisciplinary teamwork here also, like in situations where the doctors find it difficult, or the nurses. It is not like doctors or nurses alone. It is a teamwork. Doctors, nurses, or social workers, whoever is finds actually whoever the patient feels comfortable with, or the caregiver do the psychosocial.
Yes, doctor.
Sorry, Raju, am
Doc,
I breaking?
you broke in between, but we could hear it.
Okay.
Dr. Chetna has also commented like one staff can be dedicated for this purpose, especially allocating rooms for assessment. I think all adds to it.
Yeah,
And some kind of
yeah, yeah.
triaging
All,
can be.
yeah.
Doctor, just wanted to add in like social workers can be the second person in which we can talk to patient, and also we have good number of volunteers who are actually trained in palliative care to do the basic assessments too. Yes.
Yes, yes. We have volunteers also who can help us with this. Um, so it is like, it should be a teamwork. It is. I'm sorry, I just left out. Thank you, Raju, for reminding me. It's not the doctors, nurses, or the social workers alone, but the volunteers are also helping us with this psychosocial assessment of the
Thank you, doctor. So, ma'am, we have also
patients.
one question like, does your team support with medication in resource limited setting or poor people? Staff can be trained, and also in Dr. Anupam has mentioned about DOTS program. We have home visits by health workers. Similar lines could be used for palliative care too. So, Dr. Anupama, can you explain what you actually wanted to ask her?
Yeah, you are
Uh,
able to hear me?
uh,
Yes, doctor.
yes.
Yeah, nothing actually. Yeah, shall I?
Yes, Dr. Anupama, you can
Please,
speak.
Yeah,
please.
yeah. When the patient is diagnosed as a case of tuberculosis, so we send our home health visitors to go home and visit their home environment and look into the aspects of adherence and compliance with the therapy, and also counsel them as well as their caregivers regarding the various schemes that are offered by government, and also the benefit that they'll get actually through that. So by all these they are always in touch. By later on they do it on phone calls, but at least 2 or 3 visits. And when the patient doesn't come for his visit or doesn't come for medicines, these people will go home and follow up the case also. So something like that I was trying to say in palliative. It's better that they go once at least and visit the home, which she was telling that once you go to the home, you'll know the circumstances, how they are staying. So that's what I meant.
Thank you so much, ma'am. And there was also a
Yes.
question from Dr. Chetna regarding how frequently home visits are done. If it's about the psychosocial home visits, it is based on the requirement. That is, when we go for a home visits, we get to understand that this visit is not enough. We need to have another visit, and it will be our liberty. Like, we are free to set a day for the next home visits when the person is available at home. Like, before, prior to the visit that we made, we will be making a phone call based looking at the availability of the person, and according to that we will be making the home visits. If it is regarding the medical part, usually we will be seeing the person once in a month, and based on the need, or based on the need, the patients are free to call our home care in charge nurses, and based on that, the assessments will be made over phone, and if it is required, the home care will be done within the 2 or 3 days possible. That is what we actually practice in Delhi, India.
So, Teresa, I would like to add something more to it. So, regarding for physical needs, if we are doing the home visit, it would be the symptom based, and usually it is not like monthly or
Dr. Amrita, we have.
It could be once a week management. Upon the symptom management, we usually plan our home visits. So the frequency of home visit depends upon the need. And the initial assessment, I would like to add to what Treesa said, is that the initial assessment would be done by the clinical team, maybe a doctor or a nurse, whoever is there, and where more of psychosocial need is felt would be handed over to the medical social worker, where the medical social worker will go in and do a detailed assessment and covering all the aspects of the patient need.
We have another question coming in. How do you arrange financial aid?
Okay, just to answer, usually what we do is like we facilitate them, or we make them aware regarding the existing schemes. That is, there are national schemes, pension schemes are there available. Also, for the people who are ill, there are also other pensions and other support schemes. That is for the social justice department is providing assistance for the persons who are undergoing dialysis. Also, those who are diagnosed with cancer, they are also supported with a pension for every month. So we'll be doing is like we'll be facilitating them to the available systems. So if that fails, or if we understood that the family requires an additional support, what we do is like we make a story out of them, and what we do is like we'll reach out for help to the other sources that we are aware of. We'll be connecting them with the resources or with the noble people who are willing to help the people. So that is what we usually do. We connect them to the resources that is available.
Dr. Amrita, you wish to add something more?
No, I think Treesa has completed everything. Yeah, that's it. That is how we do it.
Doctor, I think we can move on to case.
I think it's time for the case presentation. I would like to invite Dr. Marina, who's doing the case presentation today. Over to you, Dr. Marina.
Thank you, ma'am. Am I audible?
Yes, you are.
Yes.
Thank you. So today's case presentation is about a 10-year-old child. She's a girl, and she was diagnosed with acute lymphocytic leukemia, and she had a relapse, and she had pain. She also had a non-healing chronic discharging sinus with the right sacral region, and blindness, probably due to ischemic optic neuropathy.
Doctor, you can
Sorry,
continue.
1 second. Okay. So, presenting complaints, she presented to Shalom was the palliative care center where I was working, and she was one of our patients. So she presented to Shalom Casualty on August 2019 with complaints of blood tinge discharge from the right lower back for almost a month and exacerbation of pain in the right upper limb for 5 days. History of illness, she was in apparent good health till June 2017 when she was started having high-grade persistent fever, which was not associated with chills and not responding to antipyretics. She also had severe pain in her wrist and shoulders. She was evaluated at various hospitals and was diagnosed to have acute lymphoblastic leukemia. She was started on chemotherapy thereafter. Within few months of initiation of her treatment, her symptoms had subsided, and she received chemotherapy for almost 2 years. It was in 2019 May when she again started experiencing severe pain in her shoulders and wrist. The mother also noted a discharge from her right sacral region, which was not healing. She also had severe pain in her thighs, and it was very difficult for her to walk or squat following that. She was again taken to the private hospital where she was initially diagnosed and treated, uh, and she was diagnosed to have a relapse of ALL. The family was told that the disease had progressed beyond control, and they had advised the parents to take her home with antibiotics for the discharging sinus and paracetamol for pain. So it was during one of these visits uh, to that hospital by a palliative care nurse that we found this patient, and then the patient referred her to our center where she had come with her family. So, an examination, she was conscious, oriented, in distress. She was crying in pain. She was thin built, weight was around 20 kgs. Pulse was around 100. Her pulse was 112 per minute. Saturation was 98. She was afebrile. She had mild pallor. On local examination, there was a blood test discharge seen over the right sacral region. Small opening to less than 0.5 centimeters seen. Overlying skin was not erythematous. No local induration was seen, and tenderness was present. The chest, bilateral equal normal breath sounds were present. She was tachycardic. Heart sounds with upper abdomen was soft, and liver spleen were palpable, but there was no tenderness. CNS reflexes were present. Power was 4 by 5 in lower limbs. Upper limbs was 5 by 5. Tone was normal. Pain score was 9 by 10. So she had received her treatment from Kalavati Hospital. Her parents did not have her treating documents with them, and she was diagnosed to have relapse in July 2019. So her parents were migrants, and in between the shifting of houses, a lot of the documents was misplaced. So we could not have all the reports, and few of the things we had to go by their word. Her parents also took her for Ayurvedic treatment in between, hoping for a cure. That was before she had come to our center. And these tablets were quite expensive. It was around 4,500 rupees for some 15 tablets, and she had to take those every day. She, at the time of admission, was taken syrup Septran for the wound on her right lower back and was on paracetamol tablets to around 250 mg uh, PRN she was taking. She was enrolled in the palliative care program and was by our center and was started on uh, regular paracetamol, and initially Brufen was given PRN. Local wound dressings were done with metronidazole crush tablets. Psychosocial aspects. Her father worked as a laborer at an Atachi suitcase factory with a monthly salary of 6,000 rupees. He had taken off a loan of around 2 lakhs from his factory, which he was struggling to repay. Later, for the Ayurvedic treatment, an additional loan of 50,000 rupees was taken. Her mother worked as a housemaid. Her monthly earnings was around 2,000 rupees, which was never a stable job, because whenever this patient was in pain or she had to be hospitalized, the mother could not go for work, and it did affect her monthly earnings. She had a little brother who was 8 years old and was studying in third grade. Twice, due to the lack of attendance, his name was struck from the school record. So he was studying at a government school, and whenever she was admitted in the hospital, he could not continue his studies, or whenever the parents had to go for work and she was sick, he was the one who was staying at home and taking care of her. The family stayed at a rented house at an overcrowded area in Delhi. They stayed at a single room, and inside the room there was, on one side there was a gas stove with few utensils that were kept. That was the kitchen area, and just right next to it was a bed. And then just within a small distance there was a area that they had assigned for doing laundry and washing the dishes, and later it became a full-time washroom for the patient. As the disease progressed, the symptoms and symptoms worsened. Agony increased for both the parents as well as for the patient as well as the family. Parents were hurt to see their daughter in pain, struggling with life. Patient was angry, agitated, irritable, sad, and lonely. She wanted to play and go to school. However, she could not even manage doing her own course by herself. Medication. Initially, she was given paracetamol 250 mg every 6 hourly, ibuprofen 200 mg thrice daily. Septran was continued for her. Metronidazole tablets were used for dressings, and MCIT was given for any pain. MCIT was given for vomiting. Her pain reduced for a few days. However, there was another exacerbation of pain which stayed longer, and she was started on morphine. So we had started or on morphine 5 mg every 4 hourly at 6 a.m., 10 a.m., 2 p.m., and 6 p.m. And then at 10 p.m. she took double the dose, that is 10 mg, and PRN doses were given as per the requirement with regular paracetamol 250 mg every 6 hourly. And Dalcolax was also added. Volini gel was given for the local application on her arms, and ibuprofen was given PRN. She was discharged on these medicines, and her morphine requirement was reassessed after a week. doses were increased after assessment to 10 mg at 6 a.m., 10 a.m., 2 p.m., 6 p.m., and 20 mg at 10 p.m. along with PRN doses. So it was very difficult for them to bring the child to the hospital every time. So our palliative care nurse used to contact the mother over phone, and whenever there was any problem, they used to contact her, and we used to tell them that what needed to be done. And home visits were done every at least every 2 weeks. Home visits were done to their house because she was really sick and they were in a really bad state. But in between, when the requirement was more, our staff used to go more frequently, and almost daily they used to call her on over phone, and they used to confirm about her health status. So she was discharged with these medicines. Our palliative nurse would visit at her home once every 15 days, would spend time with her. Instructions were given to the mother on phone, and pain spikes were managed with additional morphine. So during these home visits, there were days when the mother was not at home and she was at work, but it was not possible always to ask the mother to stay back at home, and the parents were quite comfortable. So our nurse would go, and either the neighbor would be there, and her and the little brother would be there, and any instructions that had to be given were given to the mother on phone. But we used to go and spend time with the patient at home. The family was financially overburdened and therefore was enrolled for the monthly provisions that we provided from our center. Money was given from some of the staff collection for their other needs. Mother was given also prescription for morphine, which could be obtained from the government centers, because in between there was a shortage of morphine at our center. So and it was getting a little expensive for them. So we thought that we could write for a morphine prescription for a longer duration, and the mother, she could easily go and obtain this morphine tablets at a very cheaper rates. When the patient had exacerbations, she was admitted to a center free of cost. Her brother would stay on the next bed with her, and parents used to stay at the hospital after finishing the day's work. So the parents trusted us enough, and that they would leave the child and the patient and the brother with us at the hospital, and they used to go for work and come back, because for them even missing a day's work would cost them a lot of money, and they could not afford that. As she expressed a desire to go home, she was discharged, and PC team coordinated with her mother. Within few months, her headache worsened and she became blind. By this time, her mother had left her job and was staying with the patient full time. And we lost this patient on 16th October 2019. I'm sorry, there is a error there. So these were certain things that our palliative care team did to make her comfortable at home and at the hospital. So what we did was we had joined the hospital bed so that she and her brother could stay together, and whenever she was not in a lot of pain and she was comfortable, she could stay. They had bigger area to play and spend time. Nurses spend their free time teaching her brother mathematics and certain languages and giving him assignments for the day. He was a really smart child and he wanted to learn, but due to the problems at home, he was not able to study. And he used to always finish those assignments that were given to him for the day. And even this patient, she was given paint things for sketching and painting, and she used to enjoy whichever time, whenever she got and whenever she could, she would always paint or draw something. And counseling was provided for the patient as well as the family members by our nurses and even by doctors. So we have this team of children who are undergoing training for life skill education, and they are mainly the children who are either uh, HIV positive, or their family somebody is affected with HIV, or they are cancer survivors. So we have a group that is made, like a kid support group that is made, and they are taught things by our team. So those so when we had one of these meetings, we had told and shared to these kids about our patient, and they wanted to make something for her. So they drew some sketches and painted something, and all of them went and they gifted her that. So her one of her wishes was she wanted to celebrate her birthday and she wanted to cut a birthday cake. So we had initially planned a surprise at the hospital, but later it was uh, they had planned that they would bring the patient to the hospital. They would bring her to the hospital, but because she became really sick, so she could not be brought, and we few of the staff, they went to her home with a cake. After her death, the palliative care team stood with her family, continued the home visits, and provided ration. And they were encouraged to talk because it was a very difficult time for almost 2 years. The whole family, everything in their life was about taking care of their little girl. And the day she died, after that, they were all left with a void. So it was very difficult for them to come out of it. So we kept encouraging them to come to our family get-togethers. And even the child, even her brother, he was encouraged to come for the program, kids program, and they involved in other activities. Her brother also became very quiet after her death and was enrolled to the adolescent program. Our staff also went and talked to the school authorities, and his readmission was done. Bereavement care continues to till date. The summary is: 10-year-old child was diagnosed with a relapse of ALL. She presented with severe pain over her shoulder and limbs. Her pain was managed with regular morphine and paracetamol, ibuprofen. Her disease progressed and she had a pain free death on 16th October 2019. Palliative care was provided to the patient and the family. Bereavement care is being provided to the family. Discussion points: child was not taking orally, and plan was made to start IV fluids for a short while she was in the hospital. The family was willing, but the child refused. So what should be done in such a situation? Then psychological support, not just for the parents but for the young sibling who was also the primary caregiver. Heavy financial burden on the family with the debts taken for the treatment, and how to support them to reduce this burden. And how do you convince a young child who is lonely, angry, and is suffering? Also, before we start the discussion, yeah, this is a picture. Like, this was all the sketches and paintings that those kids had drawn, and then we had stuck those at the hospital wall. This was just right next to her bed so that she could look at it and she could have a good setup at the hospital. Thank you so much.
Uh, Thank you, Dr. Marina, for that great presentation. First and foremost, I would like to congratulate Dr. Marina and her team for the wonderful work they have done for that patient. Uh, Actually, it looks like a good example or a wonderful example for how a palliative care team can support a patient in need.
Thank you, ma'am.
Moving on to the discussion points. So the first point is the child was not taking orally, and a plan was made to start IV fluids for a short while in the hospital. The family was willing, but the child refused. What should have been done? I would like to hear from the participants what they think about that.
Dr. Amita, there are some of the comments coming in. Could a counselor have a help convince a child? Can divert attention even if temporarily?
Uh, I think that is about the paintings. What since there are no more comments from the participants, I could okay. So I think somebody has IV fluids at this stage without child's consent would add to the children are scared of needle pricks and refuse IV. Okay, yes, yes, Dr. Vinay. uh, yeah, we got different comments, but I think what I would suggest would be to explore why the child was not willing for an IV infusion, to explore why the child has refused or showed unwillingness. It could be due to multiple reasons. That could be the first and foremost point that we should attempt to see why the child is not willing for this procedure. Then,
Um,
yeah.
Ma'am, in this case, it was, yes, definitely the fear of needles. And because previously also the child was admitted on and off at various hospitals, and she was really scared of needles. uh, she used to come to our center because over the time we convinced her that she will not be pricked unless it was really necessary, and then she didn't have a problem in coming to our center. But when a stage came like that, when we had to think about starting her on IV fluids, because we were thinking that she's getting dehydrated, she's not taking orally much. But then she was really not willing. And yes, we did try to poke her once, but then we could not get her, we could not get the IV line. And then the and then it became very difficult. She just tried once, and then we just gave in. And when we started glucon d powder and more of fluids, and then we convinced the child that if the child tries to take everything, at least something, uh, uh, like even after in little time, then we will not, we will try to not start any more IV fluids for the child. So with great difficulty, but yes, the child did drink more water, more juice and glucon d. And then we did not, eventually we did not start. But this was one of the, in between we were worried about this thing, that the child became sick and there comes a time then we have to start IV fluids or IV for any medicines. Then what will we do?
So, Marina, my next question would be, uh, what what was the condition of the patient when you wanted an IV fluid? Would that fluid infusion would have helped the patient at that situation? Would be another question that would arise in my mind.
The child was slightly dehydrated, but it was the time when she was not willing to take anything orally. So she was really angry with everyone, and she did not want to eat, she would not drink. So that was the time we thought that if she is not at all taking, after trying to convince her, the family is trying, then we thought that she was dehydrated, she was mild to moderately dehydrated. We thought that before the situation worsens, we should start IV fluids. So that was why we made an attempt to start an IV fluid for her.
So another concern that comes to my mind is that a patient in an end of life, uh, with an IV fluid infusion, are we going to benefit her anything with that? So usually, nearing end of life, their energy requirements are all shutting down, and hydrating the patient might not benefit much.
Yes, ma'am.
So usually, what we suggest is that we try to uh, motivate the patient to take orally as much as possible. Maybe
Yes, ma'am.
very less quantity of fluid, but food maybe, but still whatever is possible orally, we try to motivate her to take it orally. And also we try to encourage that social eating. So whenever she's left alone, she might not feel like eating. And the patient, I think at some point of time, she was undergoing some Ayurvedic treatment. I don't know whether
Yes,
she
ma'am.
had some food restrictions also. So motivating the family to provide her the whatever food she likes would be another suggestion.
Yes, ma'am.
And in our setting, usually, so it is at times we find it really difficult to convince the family, the caregivers, that fluid infusion at this IV fluid at this point of time might not benefit the patient much, and the caregiver might be very upset about it. So in such situations, we go in for subcutaneous infusions. So that is another source of fluid infusion that we do in our settings, subcutaneous fluid infusions.
Okay, ma'am.
So,
And ma'am, I think it was taken for us, but how much of fluid can be given subcutaneously, ma'am? Like
uh,
fluid.
so usually in our settings we give it is only normal saline that can be given subcutaneously. Usually that is being given in our settings, and that is usually 500 ml over 6 hours. We give
Okay.
maybe 1 liter per day.
Okay, ma'am. Thank you, ma'am.
So yeah. So shall we move on to the
Yes, doctor, we can move on to the next question.
okay. So the psychological support not just for the parents but for the young sibling and who was the also the primary caregiver. Any suggestions from the participants? So it is really important that the because being the younger member in that family, that sibling would have been the person who would have enjoyed more love and care from his parents. But now the entire attention would be on the patient, and he might be disturbed with that. So it is very important that we talk to the sibling and address his concerns, explore what exactly is he going through, and how important it is really important that he should know what his sister is going through and what the entire family is going through, and how he can support the family and his sister. That is what I suggest. Would Teresa like to add something to that?
I agree with you, ma'am. Like the psychological support, as we have told, it has to be extended to the family as well. And being the brother, like it was also told that he was a caregiver when the parents were not there at home. So he is a person who have actually witnessed all the sufferings that that his sister have gone through. So maybe they may be so attached, like the beds were also kept so close that they will be never separated. So in the future, when there is a situation that there will be a void due to the absence of sister, so the younger sibling has to be made prepare about that. So as ma'am told, we need to understand what exactly are the concerns that the brother is having in his little mind. He's just in third standard, so his confusions or his questions need to be answered based on in a simple language that is understandable for him, in order to get him prepared about what exactly the person is going through. Also, the family members, they are called the invisible patients, that is a caregivers. They are also, they will be presenting themselves in front of the child, happy and satisfied, but inside they may be crying or they may be suffering a lot. So separate sessions can be conducted with the parents and trying to understand what exactly are the concerns that they are having, and they have to be provided with supportive counselings and supports.
Thank you, Teresa. Now, the moving on to the next point, heavy financial burden on the family with the debts taken for the treatment, support to reduce the burden. I think Teresa can comment on this also.
Already, the
Yeah, Teresa has already mentioned in the, I think during her session itself, that she has mentioned that we can find alternate source of support system for the financial support system.
exactly.
Is that, yeah?
Also, Marina ma'am have told that they have already arranged a free accommodation for the patient as well as the family. Also, they have helped them with the managing the financial situation.
Monthly range.
Monthly rations were provided. So all these things have actually contributed or helped them very much. And other than that, if they required some extra help regarding the financial burden, what we can do is, like, we can connect them with other local NGOs or other organizations which are willing to support persons in distress. So we can be connecting them with other sources. That is another thing that we can do.
And I think we can also make use of social media or fundraising by story writing. I think we have been doing that, isn't it, Teresa?
Exactly. The stories can be given out in social media so that the people who are willing can support the person and the family.
So moving on to the next point, How do you convince a child who is lonely, angry, and suffering? Yes, Dr. Chetna, it's really difficult. But first and foremost, we should try to identify what exactly is the reason for her angriness. What exactly is the reason? So we cannot assume what she is going through, but we need to talk to her and understand what. So this angriness might be the reason for her. This anger might be the reason for her loneliness, and that can add to her suffering. So we would have to explore what is the reason behind her anger, and yeah, and accordingly we need to intervene. That is what I would suggest.
Um, ma'am, the anger was yes, because she could not enjoy a normal childhood. Because whenever, even when she was at home and she used to see the kids in her neighborhood go to school, she would want to go to school, and would like to go outside with them and play. But because of her health, it was very difficult for the parents to do this, like let her do this, and for her to get the strength to do it. So all these things, and then not able to decide what she wants to do, and like always being dependent on others for every little thing, even though she's a child. And
So
almost all, sorry ma'am, like the children are dependent on the parents for care, but she wanted to do certain things on her own, and it was with all these things the anger just went up.
yeah, I think acknowledging her anger and making her feel that you guys are with her and understanding what she is going through, and also reciprocating that you are understanding what she is going through might make some difference to her. And the support, I'm sure we cannot like let her, she is in such a position that her anger is genuine, and but we can support her, like we can support her, we can try to acknowledge what she's going through, and try to help her out in this situation along with the family members. And of course the measures that you have taken, like helping her continue with her paintings, the cake cutting that you have arranged, and which was not possible, you have sent cake her home, all this would be such measures that to convince her or to make her feel that the entire team is with her and she's not left alone. So these are the gestures by which we can make her feel a bit comfortable, maybe a bit comfortable.
Thank you ma'am.
Okay.
Uh,
Raju,
any final questions more, Dr. Marina, you wish to ask?
No ma'am.
Okay. Dr. Amrita, I think we can wind up our session.